All right, we're
All righty. Everybody, I'd like to introduce you to Dr. Matthew Eschelbach. Dr. Eschelbach is our Assistant Medical Director. He is located in Redmond, Oregon. And as you can see on the screen there, he is the Medical Director of EMS and Trauma at St. Charles Medical Center there. He teaches a lot on the lecture circuits for EMS and has been a wonderful lecturer for these MD roundtables. So I know you're going to enjoy this quite a bit. You will have to pay attention. At times he may stop and ask you questions. If you have questions or you need to answer the question, just unmute your microphone and talk. And then when you're done, please remute your microphone so that your noises around you will not bother the other students. And I may check in at the end as well to make sure that you're still here, so you do have to participate. That having been said, Dr. Eschelbach, they're all yours.
All right. Good evening, everyone. So I went skiing today and was stuck on the lift for 15 minutes. And then I said, well, I think I'm going to do my topic on hypothermia because I felt like one of my own patients. All right. We're going to talk about hypothermia because it's that time of year, and try and hit this lecture at least once a year to make sure we keep the topic relevant. All right, very good. So hypothermia, what is it? It's defined as a temperature less than 35 degrees centigrade or 95 degrees Fahrenheit. Greater than 700 people die each year in the United States from hypothermia. Half of those are at the extremes of age, 65 or older at greatest risk. Keep in mind that there are 4 ways to lose temperature from your body. Conduction, which is a transfer of heat by direct contact. I'll show you a little picture with this in just a minute. Convection is a transfer of heat by movement of heated material, such as the wind taking away heat from you. Radiation is loss of heat from non-insulated areas. That's why, people are always told to wear a hat. And then there is water evaporation or respiration, which we do through exhalation. And the faster we breathe, if we're out in the environment losing heat, the faster we can lose water vapor. How much of that is lost? About 65% is radiation, conduction 2 to 3%, convection up to 15%, and evaporation 20 to 35%. So here's a nice little picture for you to understand. Here's conduction where he's sitting on the rock, losing heat by conducting heat into the rock. It could be sitting on a snowbank, it could be sitting on a bench. Convection, the wind is taking it away. Evaporation is wetness being lost. Radiation and respiration. This is another way of looking at it. This is heat loss from the military style. It's still the same thing. Conduction to the ground, convection, radiation, evaporation through sweat, and evaporation respiratory. Most of us don't think of cold as evaporation and sweat, but we still lose a fair amount, not a whole lot, but 2 to 3% of our body heat from evaporation. All right, what is the treatment in the field? This is a general, very busy slide, but you can see that our range of treatment of hypothermia ranges from 37, which is normal body temperature, all the way down to 27. And we'll talk about that. Really, the bottom of our scale is about 28 degrees centigrade, and we'll go through that in a few minutes. So if you break hypothermia into 3 different categories, mild hypothermia, 33 to 35, which is 91.4 to about 95 degrees Fahrenheit. Usually you make physiologic adjustments to retain heat. Moderate hypothermia, which is 32 to 34. You're not moving much, your metabolism's slow, you decrease your oxygen demand, you decrease your CO2 production. And then severe hypothermia, which is less than 32 degrees. Some will say 30 degrees centigrade, which is about 90 Fahrenheit. And that's where shivering ceases. So let's break these down. We'll start with mild hypothermia. You wind up with an increased metabolic rate. You get maximum shivering and thermogenesis at this point. You can, at the bottom of the scale, get amnesia or difficulty thinking, dysarthria, which is difficulty talking, and ataxia, which is difficulty moving your limbs. You might lose coordination. Typically, you become tachycardic and tachypnic, breathing quicker to generate more heat. In general, you have a normal blood pressure. Moderate, you can head towards stupor. There's usually no shivering in moderate hypothermia. These are the areas where you can start to get bradycardia and AFib, where your blood pressure goes down, respirations go down, and your pupils will begin to dilate. And then again, severe, most of the time severe hypothermia, you're in a comatose state. There's no corneal reflex. That's where you touch a piece of cotton to somebody's eyes and they don't blink. Your blood pressure's way down. The maximum risk of AFib is at about 22 degrees centigrade, but less than 32, closer to 30, you'll start to see AFib. Very often people stop breathing, their heart can stop, they no longer have reflexes and their pupils become fixed. And essentially you get a flat EEG. Now that's not EKG, that's EEG. That means no brain waves at about 19 degrees. That's popsicle. All right, what happens physiologically? Above 32 degrees, you've got vasoconstriction. We'll talk about how that saves limbs and causes loss of limbs in a few minutes when we talk about cold injuries. There's usually shivering, and you maintain a basal metabolic rate. Below 32 degrees, you stop shivering, and again, below 24 degrees centigrade, most of the time you've already reached death, but there's absolutely no metabolic basal rate at that temperature. EKG changes happen, and they're quite varied. Hypothermic changes in the EKG may induce life-threatening arrhythmias. I'm going to introduce you to, in a few minutes, Osborne or J waves. There's also T wave inversion, prolongation of the PR segment, and arrhythmias may include a bradycardia or a very slow AFib or VFib, or even asystole. And usually it's a typical progression from sinus bradycardia to asystole. Here's the Osborne or J wave, discovered by John Osborne in the early 50s, and he found it in patients when their temperature went down below 33 degrees centigrade. I have seen it prior to that. I've seen it at higher temperatures, And usually it's seen in about 25 to 30% of patients. It's a positive negative deflection, like you see there. It looks like a little hitch in the Getty up there. You can see it here. These are all Osborne waves. And you can also see in our inverted waves like AVR, it's also present. Notice the chaotic baseline tending towards a problem of the baseline itself, tending towards greater arrhythmias. Here are other J waves in a different patient. Well, what's happening with the heart during hypothermia? And what's happening is the hypothermic myocardium is extremely irritable, and ventricular fibrillation could be induced by interventions that stimulate the heart through rough handling of patients. That's why you'll see in several slides, when we're talking about when you handle these patients, you have to be gentle with them, particularly if and when you're starting an IV, or when you get moving on these patients. If you start moving their limbs around too quickly, you could be pouring that cold, non-circulating limb blood and water back into the body core, which makes an already irritable heart more irritable. So what do we do about treatment? Well, the best thing to do is to stop further heat loss. Begin the warming process as quickly as possible with passive external warming and active external warming. When we get to active internal rewarming, we'll talk about that. That's warmed oxygen and IV fluids and certain procedures that we can do to warm the core of the body. The most easily applied thing to do is on the left here, and that's the hypothermia wrap, where we take a warm water bottle and you put it in key areas such as the nape of the neck, the groin, or in the axilla, and you wrap that patient in a warm blanket. This is what ski patrol does very often when they transport patients to our little clinic at the base of the mountain. And they've got hot water bottles placed in these areas where you've got the most greatest area for treating, and then you're trying to prevent that person from losing any further heat, and you're trying to warm them up. To the right is active internal warming, and we'll talk about that in a few minutes, about different ways that you can do interventions that aren't really ACLS or EMS type of interventions, but usually are done either in the operating room or in the emergency department. Very often you're going to try and maintain a horizontal position. A vertical position may compromise cerebral and systemic perfusion, so you're going to try and keep them lying down as much as possible. Again, avoid rough movements and activities and handle the victim gently. During a CPR, intubation, bag valve mask ventilation, or even starting an IV, you're going to be very, very gentle so that you're not pouring that cold, constricted blood back into the core. And you want to do this very, very slowly. Cardiac arrest can occur, and again, it can occur at any point along the spectrum, but generally it's with a severe hypothermia less than 32 degrees. If VFib is present, general recommendations are to defibrillate ×3 and then just try and get warm humidified oxygen going as quickly as possible with warmed IV fluids. You want to avoid overhydration, but you want to try and get warm fluid into that person. If the temperature is less than 30 degrees centigrade, that's less than 86 degrees Fahrenheit, CPR, limit the shocks to 3. Some texts will say only 1 shock. Withhold IV meds because they usually don't work, and continue rewarming. That's our best treatment at this point. So going over passive rewarming again, passive rewarming, the body has an endogenous heat production that comes from shivering and increase in metabolic rate. The body also releases TSH and sympathetic drugs such as adrenaline, and that will cause exogenous heat production in the patient themselves. It involves also decreasing heat loss. Try and remove the patient from the cold environment as soon as possible. Remove wet clothes and provide a blanket. It's better to cut the wet clothes off and put something dry on them as soon as possible, and provide them with a blanket to start the rewarming process. Keep in mind that during passive rewarming, oxygen consumption is going to go up greater than 90%. CO2 production can also increase, so our end-tidal CO2 might go up. We might be forcing the body into anaerobic metabolism. And generally, we're going to try and get a warming rate, not too quick, about ½ degree centigrade to 2 degrees centigrade per hour. The method of choice for mild hypothermia is passive rewarming, as we've talked about, and it's also an adjunct to moderate hypothermia. Active external warming, heat to body surfaces such as heating blankets. These can be fluid-filled or air blankets. We have in the emergency department things that we call bear huggers. Radiant warmers can be brought in where you're actually, like you might see if you're going out on a brisk fall evening where you've perhaps at a restaurant or bar, and they have the radiant warmers that are that will produce heat. Immersion in a hot bath is one way of doing things, but keep in mind you're going to have a very large area to do that, a specialized area, and that hot bath is going to have to be maintained hot. This is not something you would do in the field, obviously. Water bottles and heating pads are the easiest thing to do that. And there are chemical heating pads where you just like there's a chemical ice, you just twist, and people use these all the time for maybe just their hands. If they're skiing, they've got little packets that are activated by air. You expose them to the air and they start heating the patient up that way. It's less effective than internal rewarming if the patient is vasoconstricted, and we'll talk about that in a few minutes. Keep in mind there's something called afterdrop. Afterdrop is when you start the vasodilation process of the extremities, and you're starting to warm up the extremities, and now that cold blood and water dumps into the core, and you get a quick drop in temperature again. Keep in mind, warming rates are like we said, 0.5 degrees centigrade to 2 degrees centigrade per hour. If there is a circulation problem, it may be decreased by applying devices to the trunk only, and you might need to add them to the extremities as well. There are very, very few prospective controlled studies comparing methods. That's the difficult part. Most of this is common sense, but common sense we can't do experiments on. It's hard to do a controlled study. Well, here's what we're going to do. This half of the group we're going to warm up, and this half we won't. It doesn't seem logical to do that. You can't really design a good study that way. Again, to get the core rewarming, these are the things that are done, I have done, and you're taught to do in the emergency department. And a few of these are actually done only in the operating room. You're going to start warm IV fluids and give warm, humid oxygen with lots of moist, humid O2. Peritoneal lavage is a nick underneath the umbilicus or belly button, and you're actually going to put in a lavage tube and pour warm water into the belly. Gastric lavage is putting a nasogastric tube into the stomach and putting water in that way. You can put a catheter in or a rectal tube and warm the person that way. You could put a chest tube in and warm up the mediastinum or the lungs that way. There are machines called diathermy. If anyone ever goes to a chiropractor, sometimes a chiropractor will put you under a diathermy machine that'll warm up your muscles through vibration. And then there's extracorporeal circulatory rewarming, which is essentially a heart and lung machine. And sometimes that might be the only way to save a patient, is to hook them up to a heart and lung. There was something several years ago, it must be 20 years ago now, where they talk about the Oregon experience. What happened was a small Lutheran school on a spring day went up and hiked on Mount Hood, also known as the Mount Hood experience. And then they were caught in a freak storm, and they kind of had to dig a snow cave and huddle together. And we're talking about upwards of 20 students and teachers were caught, and they had to be rescued by helicopter and search and rescue. And some of the ones that survived are the ones that were transferred to places like Oregon Health Sciences University and Samaritan Hospital, where they're actually able to take them to the operating room and hook them up to a heart-lung machine and warm them up that way. You're going to use saline, not lactated ringers. Shorter tubes so you don't lose as much heat. You can microwave the saline. Don't microwave D5W because that will congeal the sugars. But the Annals of Internal Medicine in 1984 and 85 said you take your liter bag, and for 2 minutes at high power, will give you about a 39-degree bag of saline. Do not use that for packed red blood cells, of course. That'll break down the red blood cells and cause transfusion reactions. Warm humidified air, usually that's set up by the respiratory therapist in the hospital, 42 degrees centigrade to 46. It will help prevent heat loss. You don't really get heat gain from using warm O2. It's mostly prevents further loss. And it's very important in the management of a hypothermic patient. Up to 30% of the heat production is lost through the airway. All right, a couple things about managing this in the emergency department. Brentilium, which you really can't find anymore. I keep this slide in there pretty much for historic purposes. It's recommended for VFib and hypothermia, and it was removed from ACLS in about 2000, so it's been almost 20 years since they removed Brentilium. But it was really one of the only ones that showed that it would help you with the return in VFib and hypothermic patients. So it's still recommended in some textbooks. Rosen is a famous emergency medicine textbook. Still recommended by U.S. Wilderness Emergency Medical Association. Where they're getting this Brentilium, I don't know. So this is just a outlook of our hypothermia protocol. Your hypothermia protocol might be slightly different. And it's some of the basics that we talked about. On the upper left-hand side is remove wet clothing and prevent further heat loss. Maintain the horizontal position and avoid rough movement. Monitor core temperature as best as possible. Really, the only way to do this is to get a rectal temperature. And you're going to monitor the cardiac rhythm. You're going to check your ABCs, and if those are present, move forward. If not, you're going to go down the right side, which is essentially your VFib, VTAC, and CPR protocol towards the right. And on the left, everything we talked about internal warming and IV fluids. The base is what we've talked about so far. Again, with mild hypothermia, 34 to 36, and moderate 30 to 34, and severe is less than 30, you're going to get these key points that we talked about. You may see a degree here or there, difference in some of your reading, but it's pretty much standardized. Okay, now we're going to go past the rescue of the cold individual. We've saved them. And then there are going to be other individuals in the group, or maybe even some of the rescuers who get extremity cold weather injuries. There are three types: the non-freezing type, which hypothermia is essentially one; chilblains or trench and immersion foot, which are separate entities that were first described during World War I, during the trench warfare. New movie out that I have not seen called 1917 probably describes some of these. There are two freezing injuries, one called frost nip and one called frostbite. And then associated injuries, either snow blindness or dehydration. And we'll talk about these in a few minutes. All right, first off, frost nip. This is a partial freezing. It's most often described as a stinging, and it's just a superficial form of frostbite. There's usually no permanent injury. Sometimes you'll just get a mild redness or swelling. You can get paleness, like on this gentleman's cheeks here, where you get a paleness and a little bit of swelling or edema. And the treatment is essentially to remove them from the cold and warm them immediately. Second degree frostbite usually is when you get clear blisters. These can lead to numbing and burning pain. It involves the entire epidermis, so multiple layers, skin redness in fair individuals, and a grayish discoloration in darker skinned individuals, your black patients or Latino patients. Usually there's a clear blister forming 24 to 36 hours later, and they can come off, the skin can come off in sheets, and they can get persistent cold sensitivity in that area forever or for years. Frostbite is a true freezing of the tissue. The onset is signaled by sudden blanching of the skin or nose, of the ears, cheeks, toes, followed by tingling. Keep in mind, what your body does is it tries to maintain the core. So if the body's getting cold and it knows it's getting cold and it feels that surge in metabolism, it's going to start vasoconstricting, because the body will go, okay, I can live without my hands, I can live without my feet, but I can't live without my heart and lungs. So it's going to keep that core as warm as possible by shifting metabolism, and it's going to shift it away from the extremities. Frostbite has declared itself when these areas are painless. So just like a third-degree burn, frostbite is actually painless. Intense coldness followed by numbness. So third-degree frostbite, it's a blue-gray discoloration. You might get bleeding blisters a day later. Loss of sensation of the skin, where it becomes pale and yellow and waxy looking if unthawed. There's very poor capillary refill. You start to get tissue loss, and eventually you might start losing toes one at a time. And you get what are called hemorrhagic bullae. They're like blisters with blood in them, and they form in third-degree injuries 12 to 35 hours later, unless rewarming is rapid. Keep in mind, what happens in the tissue is crystals and ice are formed in the tissue, causing tissue destruction. Fourth degree is a deep blue or deeply aching color. And it's usually you get this terrible red discoloration for 1 to 5 days after the injury. And then it's characterized usually by gangrene and auto amputation, meaning the digits will fall off on their own. Usually you get permanent anatomic functional loss. It might happen to 1 or 5 toes or 1 or 5 fingers. It's difficult to say.
Okay, I lied about traffic. These dudes aren't totally mental. Just getting big air is dangerous enough. That's why they picked a mountain road nobody ever drives on, except during ski season.
All right. All right, therapeutic and non-therapeutic hypothermia. All right, we're going to talk a little bit about a case history here. So we've got a 40-year-old male, history of depression, IV drug abuse, heroin abuse, methamphetamine abuse, post-traumatic stress disorder, who attempted suicide with an intentional overdose of heroin while in the homeless shelter. He had essentially went outside and gave himself an intentional overdose of heroin, figuring that he would just slowly slip away. He was discovered by his friends, who spent several hours trying to resuscitate him by injecting him with IV methamphetamine and warming him up, and essentially he was not getting much better. This was November here in Central Oregon, and after failing to revive their friend, they decided to transport the patient to a private vehicle to the ER. Now, this was in the days before Narcan was available over the counter, as it is very much to the population now who use heroin. Very often people carry Narcan for those folks that are with them, that it will maybe unintentionally overdose and might need a little help from Narcan. The airway was maintained in kind of a interesting way. They kind of stuck the guy's head out the window. Somebody held his hair back, and they drove really fast. And they kind of just dumped this guy outside the ER entrance. One friend was brave enough to stay behind and gave the history. On arrival, blood pressure was 93/68. Saturations were only about 55%. So the open window airway method is called into question. Temperature was about 31 degrees centigrade. GCS was 8, pulse was 80, and respirations were 18. So that's not a good way to go. So on arrival to the emergency room, the patient was given Narcan. IM began to arouse, and an IO was placed in his upper tibial area immediately. Rapid sequence induction and intubation was undertaken. There was some vomitus noted on the cord. The patient was intubated. So antibiotics were started by the ER physician because he thought aspiration pneumonia was a very good possibility. Central line was begun in the right groin. Blood gas showed an arterial blood gas of 7. So the patient was very acidotic, retaining CO2. So if you were to do an end-tidal CO2, it would be way up around 65 to 75. The PO2 was only 50. Saturation was only 72%, and normal, as you know, was 95 to 100. Drug screen was positive for methamphetamine and heroin. The patient was admitted to the ICU, where he spent 4 days on a ventilator. He did develop pulmonary edema, which is like congestive heart failure and very, very common in overdoses, especially with fentanyl. He did have some aspiration pneumonia, so he was treated with IV antibiotics. He had breakdown of his muscles, which affected the kidneys, and that's called rhabdomyolysis. Slow rewarming using an Arctic sun warmer, which is what we use in the ICU to slowly warm folks up. And he had a psychiatric consultation and eventual admission to the inpatient psych unit to treat his depression. And then mental recovery, he was able to return to a normal mental state. Oops, sorry, lost one. There we go. Give me just a second. I think I had one slide I missed. Okay. All right, a little treat here for you. All right, and that's it. The end. So if there are any questions, I'll be glad to entertain them.
So would the blood in the arms be acidotic or just cold?
Say that one more time.
Would the blood in the arms or the extremities be acidotic or just cold?
It would be acidotic because there's very little exchange of oxygen and CO2 and cellular metabolism. So they will tend to be acidotic, yes.
And so what you're doing is you're essentially pouring all that acidotic blood in with the blood that's well at a normal pH, and that's what would cause and that's what causes the cardiac arrest. Well,
several things cause the cardiac arrest. Yes, you're acidotic. Also, calcium and magnesium, the heart becomes very irritable. So as the heart becomes irritable, it becomes more likely to go into VFib or VTAC. and you've got a buildup of CO2, and you've got a buildup of acid. So all these things combine for a toxic environment for the heart.
And on the, so I'm in Texas, so we don't really go over, well, I'm in like Central Texas, so we don't, I mean, we have like hypothermia, but it's not an everyday thing. And we were always told to start the rewarming process once we got to the truck. Do you recommend we start it in the house, or?
Well, keep in mind that most everything I showed you here is a cold environment due to snow or ice. And the biggest process is you have to make sure you've got a stable, warm area. Whether it's the house or the truck, it doesn't really matter. But once you start that rewarming process, it has to be continual heat. Also, keep in mind with your extremities during your cold injuries, such as frostbite, you have to warm them up and dry them out as much as possible. And you have to maintain that. So if you're in the field and somebody has a frozen extremity, and it's a 2-hour hike out, leave that extremity frozen unless you can pack them in something that's warm. So you're gonna get them as dry as possible or get them as warm as possible. But before you start thawing out frozen extremities, make sure that you can maintain a warming environment.
Okay.
Good questions, Chris. Dylan, do you have any questions for Dr. Eschelbach?
Yes, I do actually. Okay, so I found the algorithm in kind of like what you pulled up, and the algorithm in our book is actually pretty similar to what you showed us on your screen. But it looks like this algorithm is more consistent with hospital providers, not pre-hospital providers. So this might be something that you went over and I just didn't catch it. But let's say you have a severely hypothermic patient. I don't know if I was misinformed in the past, but I believe I was told to do less aggressive rewarming because if you start aggressively rewarming that patient in the pre-hospital environment, you know, that they could start having arrhythmias or stuff like that. But that might have just been in my BLS course. You know, now that there were ACLS providers, that maybe we can start treating them more aggressively.
Yeah, you're gonna be aggressive in rewarming because, you know, if somebody's 30 degrees, it's gonna take them at half a degree per hour. It's going to take them to get up to 98, 12 hours to 1 degree or 2 degrees an hour. It's going to take them at least 8 hours to get back up there. So yeah, you're going to be aggressive. And just a little bit about whether or not you're in Texas or whether or not you're in Oregon. Hypothermia happens all the time. All you need is a night that's below 40 degrees and a little bit of wetness, and you can have these things happen. So hypothermia can happen above freezing temperatures. So you all going to get, in the middle of winter, a cold rain, and if you're a homeless person in the cold rain and you're soaked, you could be heading towards hypothermia. I would start treatment as soon as possible, drying that patient, cut their clothes off, put a warm blanket on them, put the heating units in their groin and in their axilla and in the nape of their neck, and get them dry and towards the hospital as soon as possible. And of course, you're going to monitor because you know that they're going to be clinically cardiac fragile, and you want to make sure that you monitor them at all times.
Received. Thank you.
Awesome. Good questions. Carmela, how about you?
My question is, I live in Vegas, so I don't have a lot of cold around me as well either. But I've been with partners when we've picked up homeless people on a not so cold evening as well that are hypothermic, and usually alcohol is involved.
Right.
Why does alcohol contribute to that?
Well, think about it. If you drink enough alcohol, you pass out, you don't move. If you don't move, your extremities don't exchange heat, and your metabolism slows down. So whether it's alcohol or heroin or fentanyl, slowing down the metabolism is going to cause a slowness of the extremities moving and hypothermia.
That makes sense. Thank you. I just didn't know if it was something more toxicological, but that makes sense.
Yep.
Awesome.
Thank you.
Chandler Shaw, how about you?
I'm all good. Thank you, guys.
Okay, Vincent.
Okay, yeah. So you mentioned earlier about the immersing them into a hot body of water. Can you also do that through a shower, or is it just it'll take longer?
That's a little bit, Vincent, a little bit harder for me to hear. Say that one more time.
Can you hear me now?
Yeah, that's better.
Okay. You mentioned earlier about the immersion to a body of water, hot body of water, such as a tub. If the only choice you had was to use a shower, would that make a difference? Could you do that? Would it take longer for them to rewarm? How would that go?
Yeah, as I said, immersion in water is relatively rare because most of us don't have, even in my emergency department, I don't have anything that's large enough to warm somebody up by immersing them in water. But again, it's something that would be available to you, like a warm tub that might be available if you had no other way of doing that. If you're going to transport a patient, you're going to probably want to transport them warm and dry as much as possible, and getting them in a tub is not conducive for transport. But if that's all you had, putting them in warm water would be possible. It's not a standard treatment because most of us don't have a big, long, coffin-like box to warm somebody up in.
Okay, no, true. Another question I had, kind of piggyback off of, I'm not sure who asked it about the alcohol, was that as far as drugs go, specific drugs, can they affect how fast your temperature drops? Yeah.
And the answer is yes, absolutely. If you take heroin and you cause respiratory depression, you're going to slow down metabolism quite a bit. Keep in mind that your body is a battery, and while it's functioning properly with ventilation and cellular metabolism, it'll stay warm. But if you decrease either through alcohol or fentanyl or opioids or benzodiazepines, you slow down the metabolism, it's not going to exchange heat as well, and you're going to get colder faster.
All right, understood. Thank you.
All right, Mike, how about you? Do you have a question?
Yeah, sorry, I've got three. So number one, I love the open window ventilation method. That's pretty unique. But first, I was wondering, you mentioned with the Untitled CO2, we're going to see a pretty significant reading with that. I know last week we talked about for head injuries that we're looking to titrate Untitled CO2. I think you mentioned around like the 30 to 35 level. Should we be looking to do something similar with hypothermia in terms of controlling the release of that CO2 or sort of monitoring that level?
No, I would aim for 35 to 40.
Okay.
A normal Untitled CO2 if possible, unless there was a head injury involved or suspected. I don't think that you're going to aim for blowing off CO2. It's going to naturally be high, and as you start to respire that patient, whether a bag valve, mask, or a non-rebreather, the CO2 eventually will go down to the normal range.
Okay. Sounds great. And the second question I think is somewhat similar, kind of in the same vein with breathing, but looking at RSI for somebody that's hypothermic, what would be your drugs of choice for that? Because it seems like with etomidate, you probably have somebody that's hemodynamically compromised, but then with ketamine, the impact on the heart, are there concerns about
Right.
that for sedatives? And
I would probably use, personally, I would probably use some Versed, and then I would give them succinylcholine and put them in pretty quickly.
okay.
I wouldn't mess around too much.
Okay. That makes sense. And how, like you talk about movement, I mean, especially if it's a difficult intubation, at what point would you be thinking that you're moving the patient too much?
Well, the movement is primarily the extremities. So,
Okay.
you're not going to want to raise the legs and move the arms around while you're futzing with an IV. I might, in these patients, go right to an IO so that I'm not trying to, you don't realize how much you move the extremity around when you're starting an IV. So if I had a patient in the field and I had them now in the ambulance and I needed an IV line, I'd probably just put an IO in and zip it.
Interesting. Cool. And then last question. This is one where I wasn't sure if it was just a unique circumstance in and of itself or kind of a unique situation. But we had a guy 10 years ago that we ended up picking up just off the side of the road who had been lost while he was snowshoeing I'm out in Colorado. So he was out in the mountains and was trekking around. It turned out probably around like somewhere between 10 to 12,000 feet over a couple of days. So he was pretty significantly hypothermic. We got him down to the clinic at the base of the resort nearby, and they started the rewarming process. The rewarming process had started on the way down there. There weren't any fluids to give or anything like that. But when he got into the hospital or in the clinic there, it seemed like as he was rewarming, he started to suffer from pretty acute high-altitude pulmonary edema, started coughing up sputum and all that kind of stuff. Is that something that would be linked to hypothermia at a high-altitude type situation, or could it be that the hypothermia might have been masking something like that?
Yeah, hypothermia may have been masking because he didn't have good respiration. Above 10,000 feet, you're going to get a higher degree of pulmonary edema from flash pulmonary edema from mountain sickness. And the treatment for mountain sickness is to get them below the 6,000 feet level. So he may have also injured his lungs, and now that he was warm and respiring more, you start to see the pulmonary edema.
Okay, cool. Thank you.
All righty. Very, very good. Shaughnessy, have you got any questions for Dr. Eschelbach?
Sure. Actually, I live at the lake, and typically someone who might have hypothermia would be submerged in water. Would that alter any treatment decisions versus a dry air hypothermia?
No, hypothermia is hypothermia. And again, if you had an immersion victim, you're going to try and get them out of the cold water and dry as soon as possible. So the treatment protocols are the same. It's just the method of how they got that cold. Certainly, a fall in the ocean this time of year or a fall in the lake this time of year is going to lead to hypothermia.
Right. Okay, thank you.
Okay, Wes, we're to you now.
All right, so I do have one question. So when it comes to the active fluid IVs, is there a limit to how much fluids you would give them before you would stop, or is it more temperature dependent?
It would be temperature dependent and patient dependent. If they're a young, healthy person prior to this episode, I would say go ahead and give them as much fluid as they need. Keep in mind that you are going to run into things like pulmonary edema as a side effect, or if they've got muscle breakdown and their kidneys aren't working well, they're going to have rhabdomyolysis. So I would say at least be generous with at least a liter or two, assuming that it's warm enough, and hopefully transport to ED as soon as possible.
Okay, thank you.
You're welcome.
All right, Jennifer, how about you?
No, I didn't have any questions. They were already asked, so thanks.
Excellent. And Chris Oxford has one more question, Doc.
So my question is in a cardiac arrest patient that is hypothermic, our protocols are to transport and let the hospital come over. And I've always been curious as to if it takes several hours to raise them by a degree, what happens to the patient after we drop them off? Like, how do they get them warm and dead instead of just cold and dead?
Right.
What's the process for a hypothermic patient in cardiac arrest once they get to the hospital?
Well, we kind of just do everything that we just talked about, depending on how cold they are. We'll get those bear huggers going. We'll get the warm saline going. I have on occasion infused the bladder, and I have on one occasion done peritoneal lavage to warm somebody, and then we'll just slowly get them going as much as possible. Dialysis is another possibility, but that would be emergent dialysis and relatively hard to do quickly. So we just try and warm them and flood them with heat as much as possible.
Okay, so that's where your lavages and everything comes in instance.
Yes.
But you're doing that while you're also doing the CPR, or while you running a code.
Yes, exactly.
Okay.
Anybody have anything else? Oh, wait, Carmela's got another question. Her hand is up. Go ahead, Carmela.
Why do they limit it to one shock on the ACLS protocol for below 30?
Well, because the myocardium is hyper-irritable and sometimes you can go from VFib, which is a non-perfusing disorganized rhythm, to asystole, which is no rhythm at all.
Yeah, that wouldn't have been good at all. Okay, thank you.
All righty, ladies and gentlemen. Thank you, Dr. Eschelbach. That was a very timely and great lecture. We appreciate your time tonight.
All right, thank you.
Bye,
Good night.
everybody.
Good night, everybody.
Thanks. Appreciate it.